Children from socially disadvantaged families are more than twice as likely to be diagnosed with language problems. We know that whilst the famous Hart and Risley study, which identified the 30 million word gap, has a number of methodological issues, the basic findings that on average disadvantaged children grow up in less language-rich environments than their more affluent peers has been replicated in a number of settings. We also highlighted the evidence that language skills play a key role in children's school attainment and employment opportunities. The broad thrust of these findings has been repeated in more recent work, including Public Health England's Better Start in Life guidance. In our report, we went on to make a series of recommendations, including children's language development should be viewed as a public health and wellbeing indicator. More regular monitoring in children's speech and language development between the ages of 2 and 5 is needed. The more research into the impact of early language development on the live course, including a better understanding of the impact of language difficulties has on children's mental health, is crucial. And that more robust evaluation research is required to test and develop interventions aimed at supporting children's language development. This work had considerable influence. For example, the Department for Education Social Mobility Action Plan, published just 2 months later, had a considerable focus on reducing the language gap between disadvantaged children and their peers, and was the catalyst for a range of positive government initiatives, which I'll speak about in a moment. We continue to detail the importance of early language development in our 2018 report, Key Competencies in Early Cognitive Development, where we demonstrated how early language is supported by a range of factors, including children's ability to understand the intention of others. We also highlighted longitudinal evidence that children's language is highly connected to their cognitive, social, emotional and behavioural development, and is also highly predictive of academic achievement and entry into the workforce. In this work, we identified a range of factors associated with good language development, including being firstborn, being a girl, high levels of age-appropriate infant-directed speech that is responsive to the child's specific interests, and an enriching preschool education. We also identified a range of risk factors, including low maternal age, high levels of stress or the existence of maternal mental health problems during pregnancy and postnatally, maternal use of harmful substances, low parental qualifications, and high number of siblings. What's important about this is that it highlights the interrelated nature of risk factors, points to the need for an integrated approach in which early years and maternity services both have a role to play in supporting children's early language development and school readiness, and the need for joined-up services has been an ongoing feature of our recent work. Outside of these reports, speech and language continues to be a prominent feature in our work, including our work with the Department for Education and Local Government Association on the Early Years Peer Challenge Programme, which uses our Early Years Maturity Matrix as a self-assessment tool focused on the provision of local area speech, language and communication services. The DFE evaluation of this programme, published last week, noted that, according to participants, peer challenges improved the partnership working and engagement of senior leaders and supported the development of strategy and pathways. However, we should note that the impact of children and families has not yet been tested. Alongside this, we published a series of case studies of local areas which have closed the language gap, which identified a number of key themes, including integrated working, early identification, a focus on the family and highly skilled workforce, and a focus on take-up of the 2-year-old offer. And finally, the launch of our Early Childhood Services Hub, which brings together key evidence resources and planning tools for commissioners, practitioners and researchers who want to use evidence to improve outcomes for children. We are pleased that since the publication of our first report, speech and language in the early years has enjoyed renewed focus in policy making. I won't be able to cover all the recent developments, and others on this panel may wish to speak in more depth about some of them, but some highlights include the launch of DFE's Hungry Little Minds campaign, a public health approach to raising awareness of the importance of parent-child interaction, which we have been pleased to support. DFE launching the delivery and evaluation of the Professional Development Programme, a CPD approach designed to enhance the skills of early years professionals in supporting early language development. DFE, in collaboration with the Education Endowment Foundation, launching the rollout of the Nuffield Early Language Intervention, a well-evidenced approach to supporting narrative, vocabulary and listening skills for children in reception, and a range of initiatives from PHE, including in recent weeks the launch of the new Early Language Identification Measure alongside the Better Start in Life guidance to support local areas to develop evidence-based speech, language and communication pathways. So in summary, there's a wealth of evidence on the importance of early language development and a strong social gradient to that development. However, whilst there are clearly some well-evidenced approaches and interventions, we know more about the importance of language development than what works in supporting those with language delays over the long term. Reducing the disadvantage gap in speech and language development is going to require a multifaceted approach across the life course. It means addressing multiple risk factors and providing services which can meet a range of needs. Maternity and early years services, the ECE sector and primary schools all have an important role to play in this. For us, priorities include continuing to build the evidence on the mechanisms via which risk factors impact on speech and language development, evaluation of approaches designed to prevent and treat delayed development, including a focus on the long-term follow-up and whether the positive effects are sustained, further work on local impact evaluation, moving from process and qualitative evaluations to understanding the effectiveness of services, and understanding the impact of COVID-19 on early development. This should include exploring the pressure on local arrangements and we are keen to work with local areas to use our new maturity and early years maturity matrix to create baseline data on current services. So please do get in touch if you'd like to work with us on this. And finally, and perhaps most importantly of all, given the significant financial pressures children's services have been under for many years now, we need to ensure that local authorities are funded at a level that enables them to both meet the increased demand for statutory child protection services whilst providing high quality early help, including but not limited to speech and language services which can meet the needs of those at risk of poor outcomes. Thanks.
Thank you very much, Tom, for that introduction and overview of some of the policy issues and some of the work of EIF. I'm sorry, a couple of people have had difficulty in hearing some of that, but we'll come back to some of the themes, I'm sure, in the discussion as well for those who missed some of the bits and pieces of that. Next, I'd like to introduce our second speaker, Professor Courtney Norbury, who's Professor of Developmental Language and Communication Disorders at UCL. She's Director of Literacy, Language and Communication and a Fellow of the Royal College of Speech and Language Therapists, so brings both an academic and a practical practice element to her work. She studied how language interacts with aspects of social and cognitive development, and she leads the Surrey Communication and Language and Education Study, a population study of language development and disorder from early school entry. She's also a founding member of the Raising Awareness of Developmental Language Disorders campaign. And I'm delighted to hear from you, Courtney. Please carry on.
Thank you so much, and thank you for the invitation to be here. It's a huge honour. So as Paul mentioned, I'm really particularly interested in children who have language disorders, and we know from many years of research that these are very often biologically based conditions. So we know that language difficulties tend to run in families, and that this likely involves subtle differences to how children's brains are developing, and this makes language learning from typical language input more challenging. So as Paul mentioned, for 10 years I've been leading the SCALES study, and through that study we established an overall prevalence of language disorder at about 10%, and language disorders that don't have a known cause at about 7%, or on average 2 children in every classroom. We have just submitted a paper that looks at how that prevalence figure changes as a function of neighbourhood deprivation. And as Tom mentioned, we see more cases of language disorder in more impoverished backgrounds. In fact, it moves about 2.5 times from the highest neighbourhood quintiles to the most deprived neighbourhood areas, and in those areas that are really disadvantaged, as many as 20% of children meet our criteria for language disorder. And one of the great things about SCALES is that it's a longitudinal study, and we have assessed the same children repeatedly from the time they were in reception. They're now in year 9. And we looked in this paper at from reception to year 6. And the good news is that we see that all children make progress. And interestingly, the rate of progress is the same across the spectrum of ability. But what that means is that the gap between those who have language difficulties and those who don't is maintained all throughout primary school. And importantly, our index of deprivation does not predict the rate of language growth. In other words, even those children from very impoverished neighbourhoods can make just as much progress as their more affluent peers. But it does mean that closing that gap is really challenging. We think this demonstrates the fantastic work that schools do in providing a consistent and rich language learning environment. I do know of one other study that was conducted in another country where they showed slower rates of language growth for children who were living in extreme poverty. But that effect was pretty much explained by school absence. So these were children who had very irregular attendance rates and tended to leave school at younger ages, and their rate of language growth was slower than peers. And of course, this raises concerns about what the impact of children being out of school because of COVID might have on rates of language growth. So having done scales, I spent a lot of time thinking about what we might do to improve the situation. And I think what's clear from our data and data from other studies in other countries is that the level of language a child has when they start school is a pretty good indicator of the level of language they have when they finish school. And so this suggests that our best bet might be to try and enhance language skills in the preschool years. And I think that at a systemic level, the best way to do this is to really think about the quality of early years provision. So free nursery hours from 2 is a great start, but if those hours were provided by highly qualified teachers who had expertise in early child language development, that I think could make a huge difference. The second thing I would do is to improve access to specialist speech and language therapy services, because I think children who have language disorders need more tailored and individualized support to learn from the input that they're receiving. And I would definitely see those services working in collaboration with schools and being located in early years settings rather than clinics, because I think that offers more opportunity to work closely with education staff, but also with families. I think what research is consistently showing is that short-term, one-off interventions tend not to have lasting effects on child language. And I think it would make sense to stack the support in areas of disadvantage, because that will allow you to capture more of those children who are likely to have persistent language learning needs. But even if we do this well, I don't think we will eliminate language disorder. And there are many studies coming out now that have looked at the very long-term effects of enhanced early years provision. And many of them show that these positive effects tend to fade over time, especially if there's not some form of continued support when children move on to mainstream school. And I kind of think about this in terms of weight loss programs. So we all know that your weight is in part genetically determined, but environmental modifications can have a really positive impact. So if I follow an intensive intervention program for 6 weeks that modifies my diet and makes me exercise more, I will definitely lose weight, but it doesn't fundamentally change my system. And once that intervention stops, I'm more likely to revert to my default trajectory. Instead, what I need is more consistent modifications. And that means I'm unlikely to get to the mean weight for my age, but I might make a level of improvement that is enough to stave off negative secondary consequences to my health. I think language works in much the same way, that what intervention does is modify the environment. It gives children opportunities to practice things they find challenging, and it modifies the way that input is presented so that children are more likely to learn from that input. But if we take those environmental supports away, it's difficult to change a trajectory. So the real challenge, I think, for the field and for policymakers is to think about how we can plan and provide longer term support and ways in which we can enable that children with language disorders have access to more individualized support, at least at key transition points in development. And I think that might mean that we don't get everybody to a certain level of language. There will always be variation, but I hope that this would give children the language skills that they need to successfully participate in family, school, and social life.
Thank you very much, Courtney. Thank you for taking us through some of the facts and figures around how common this is and some of the impacts, and some really helpful tips and advice for what we can do. I'm going to keep moving fairly swiftly through. So I'll move on to our next speaker, who is Sheena Carr, who's Deputy Head of Children, Young People and Families at Public Health England. She leads the early years health improvement there. Prior to joining Public Health England, she was the public health specialist for Lambeth Early Action Partnership, which is one of the better start areas. She's driven improvements in child and family outcomes in over 20 years, working in the NHS and as a public health local authority commissioner of 0 to 19 services in the North London Authority. So as well as child health expertise and experience, she has also led older people's programmes and mental health for a former primary care trust in London. So without further ado, I'm going to hand over to you, Sheena. Thank you.
Thanks very much, Paul. Really happy to be here and listen to all the work that's gone on so far. It's interesting just listening to Tom and talking about the Language as a Child Wellbeing Indicator report, because that really did kickstart all of our work and what I'm going to talk to you about in a minute. That led to a partnership with Department for Education as part of the Social Mobility Action Plan back in 2017, and has really been the focus of my work at Public Health England for the past almost 3 years now. So just looking at our routine data collection on child development at 2 to 2.5, we can see that communication skills at age 2 is the most socially distributed development outcome in the early years, as my colleagues has also mentioned. There's a really clear gradient with deprivation and more so than the other domains of the Ages and Stages questionnaire, and therefore amenable to intervention with a view to narrowing that gap. So as everyone said, and I'm sure people who are on part of this workshop will agree, focus on the speech, language and communication, really, really important, the impact it has on longer term outcomes, addressing disadvantage. And we know that there's some really excellent work and pathways across the country. And I think what we wanted to do as part of our work programme is to share some of that learning and also to develop guidance and tools that could be used by all local areas across the country. And I think now more than ever, particularly important with the impact of COVID, which has meant that some children who may already be behind in their language development may have fallen even further behind. So that was very much at the forefront of our minds as we've recently launched some of our publications. So I don't want this to be a PHE greatest hits, but I just wanted to briefly highlight some of the work that we've done in partnership with DFE and shaped by our expert advisory group over the last few years. So that's included delivery of face-to-face training back in the day with health visitors. We commissioned the Institute of Health Visiting to deliver this for us. Development of pathway guidance to support whole systems approach to speech, language and communication in the early years, and a new early language identification measure and intervention led by Professor James Law and his team at Newcastle University. So just wanted to say a little bit more about each of those strands. I'm sure we'll have questions, but just to give you some of the background. So during 2018 and 2019, over 1,000 health visitors received that training, which, the aims of which were to increase knowledge on typical, non-typical speech, language and communication development in all children, and to increase confidence in identifying risk factors and application of evidence-based strategies to support families. So those health visitors received face-to-face training, and then a further 3,500 were trained via Cascade, and communities of practice were established to maintain that momentum with the cascade of training. And we know that some of that cascade was paused during COVID, but we're now getting quite a few inquiries about restarting and advice about how to do that. So that's really, really hopeful. So with the pathway guidance that we published, which also includes a supporting evidence document and case studies highlighting good practice, we wanted to provide local areas with a model pathway at a universal, targeted and specialist levels that could be implemented locally. So within those documents, if you haven't seen them, we highlight the characteristics of an effective early local system for early years in speech and language, including collaboration across the system, which I know my colleagues have already talked about, having the needs of children and families at the centre, strong leadership and a confident and well-skilled workforce. And a key part of all of this work, and I'll say a little bit more later, just really, really important that parents and carers are able to access information and advice when they need it. So we've got a parent-facing version of our pathway, which is hosted on the Start for Life website. And we've also worked closely with the BBC on their Tiny Happy People resources and with DFE on their Hungry Little Minds campaign as well. So really good sort of parent-facing information. So just a little bit more about the new early language identification measure and intervention. So the measure was based on parental reports and professional judgment and developed, as I said, by members of the research team at Newcastle University. So it was using evidence from the literature and with input from PHE, expert groups, practitioner and parent-carer forums. The model was then tested and rolled out across 5 evaluation sites, and in a nutshell, showed that the early language identification measure, or ELIM, was more sensitive than the ages and stages questionnaire in identifying children with early language needs. But I think really important to highlight that with all such brief measures, it's not just something that can be used on its own. And the really important bit that comes next is that conversation between practitioners, and in this case, we're saying health visitors at the 2 to 2.5 year Healthy Child Programme review, and the parents and carers. So the way that the ELIM was developed, so it's been delivered as a universal 3-stage process. So there's the identification part, which is practitioner observation of the parent-child interaction and a 50-word word list. So that's the assessment part. There's then the resulting conversation between the practitioner and the parent, and then, if needed, subsequent intervention. And I think what we're recommending, and we can't mandate this, but we're recommending that the ELIM process is offered to all children to ensure that parents and carers receive advice on supporting their children's speech, language and communication, and that those who need additional support are identified early. I mean, that's a really sort of high-level, quick summary. There is a 267-page report which goes into the detail of how the measure was developed, and I've read it many, many times. It is a good read. So that's published on Newcastle University's website. We have published a summary version and also a guidebook for practitioners on the measure. And what we'll be doing is we've recruited sessional trainers who'll be rolling out the training to health visitors, early years practitioners, speech and language therapists from the middle of January next year. I think we were really keen that we wanted people to hear the same messages at the same time and encourage that communication between services. I think with all of this, and especially because I've worked in local authorities for a really long time, I'm really conscious that we're putting out all of these new resources and tools in the middle of a pandemic. We know the impact on families, on local services, but we do think that the work and the new measure and intervention has this potential to be a really powerful universal tool in identifying children at the 2 to 2.5 year review. So the ELIM work and all the other work that we've done as part of this programme of work has demonstrated a real enthusiasm for a focus on speech, language and communication needs and that importance of the practitioner and parent-carer relationship. And I think, as others have said, I just want to reiterate the key to all of this work is integration, the importance of health visitors, early years practitioners, speech and language therapists, primary care, voluntary sector services working together, and also working to equip parents and carers with the skills needed to support their child's development. And I think, again, with all the work that we've developed, it's having children and families at the centre. Parents and carers know their children best, and they need to be supported with information and resources to enable them to support their children with their speech, language and communication development. So I'll leave it there. I'm happy to take questions. Thanks very much.
Thank you very much, Sheena. And it's really encouraging, I think, to hear that this work is carrying on despite the pandemic. It's so important. So I'm really encouraged by that. We have got questions coming in, so please do, if you have other questions you want to send in, please do. And please do vote up and vote. You can't vote down. You can only vote up. Vote up questions, because almost certainly we won't be able to get through all of them. So I will try and pick the ones that most people will seem to want to hear from. We'll do that after our final speaker, and I'm delighted to welcome our fourth and final speaker, Debbie Chase, who is Director of Public Health at Southampton City Council. She's worked as a consultant in public health at the council for 6 years and joined the governing body in November 2019. Her background is in academic public health, having undertaken a PhD in public health research at the University of Southampton, some people say the best university in the world, and several research roles. Her specialist areas of interest are children and young people's health and well-being, sustainable development, and getting evidence into practice. Quite a broad range of really interesting topics. So over to you, Debbie. Thank you.
Thanks, Paul. And I must say, I am in this area, but it's been wonderful listening to you all. I'm learning so much, Tom, Courtney and Sheena, and I'll pick it up in my reflections because that's what my bit is more than anything. So what I'm going to do is I'm going to paint a picture of the situation in Southampton, and we've just gone through a local government association peer review in relation to speech and language. So what that showed, and a few reflections in relation to COVID-19 as well. And as you can imagine, my day job, I've lived COVID-19 over this last year in terms of supporting the city. That's been my top priority. And so, as Sheena was saying, I'm not up to speed with all the resources that are available, and clearly I need to be. So I put a flag in my notes that I need to get up to speed with what frameworks and opportunities we need to take forward in the city. And I think that's particularly important given what I'm going to say. So for our city, our population is approximately 250,000. Southampton is almost like a northern city in the southeast. Although the southeast is relatively affluent, it's fairly deprived as a city. We have a high number of looked after children, high health inequalities across the city. So very much from a public health perspective, as we heard from Tom, we take a life course approach in the way that we work. We take the Marmot approach in terms of giving children the best start in life, particularly given we've got 60,000 children, young people up to the age of 18 in our city, and 16,000 children, under the age of 5. So our population pyramid is a sort of bulk of children and young people moving up to 25 years. So it's really important for our population particularly that we give children and young people the best start in life. The reason we decided to do an LGA peer review, and that was late last year in relation to speech and language, was recognition that we weren't being explicit enough strategically in the city about the importance of language development. As we've heard from the other speakers, it's crucial. And if you don't get it right in those early years, it's detrimental in those further years. Although, as Courtney said, school is consistent and key, but if you've already got big inequalities in those early years, then those inequalities will continue. And therefore, we wanted to ensure through that peer review process that we were doing as much as possible as a city to support it. We developed a maturity matrix. We had support from the Early Intervention Foundation and the work that we did. And what we found was we have a culture in the city of supporting early years development and speech and language. We still have 11 children's centres across the city. We have integrated working in terms of midwifery, health visiting, social care services, foundation workers, etc., community workers, all working together within hubs across the city to support. So on the ground, it's working well. We use the early ECAT programme to support Every Child a Talker, and we have a culture of that learning environment that works so well. But what we were challenged by is the fact that it's implicit. People just do it. And we're not really tracking well enough the development of that. So going back to what Sheena was saying, I'll be looking at those resources, particularly in relation to pathway guidance, and looking at whether we're tracking well enough that language development over time, because I don't think we are. We've got the integrated checks, looking at Ready to Learn, Ready for School. We've got the Early Years Foundation tools, but I don't think we do it well enough. So there's something about the way we benchmark against other areas and track over time in terms of language development to see what difference we're making. And then it's also about how we can be more explicit in the way that we strategically work across the city, across sectors, recognising the importance of that language development. So just thinking about COVID and the impact of COVID, I called on the lead practitioners a week or two ago saying, I'm doing this conference, I've been focusing on COVID and I really need to get up to speed again on language and development, speech and language. Tell me about the impact of deprivation in light of COVID-19. Tell me if those inequalities are increasing. And what they told me was quite frightening, to be honest. A number of things. One is that a number of private providers across the city, because a lot of our early years settings are either childminders or private provision, are collapsing because financially they're unstable. So we've got the situation of COVID in relation to our local economy and the impact it's having on our early years settings, and the struggle that settings were having to keep going, given that people were pulling out because families were furloughed, etc. So we've done a lot of work trying to support them as much as possible, but very sadly, a small number have folded as a result. And then the other reflection they had, which really interested me, because as Courtney was saying, and Tom and others, we've seen that difference in terms of deprivation for what measures we mark over time. But actually, in the periods of lockdown, what I'm hearing from the practitioners, it's not so much associated with deprivation. They were seeing the disadvantage that was increasing was because of parental time, parental ability, capacity. Now, that is very much associated with resources that you've got at your disposal, given levels of deprivation. But what they were saying was there's something else going on, and maybe that's the impact of COVID. So I'd really welcome Tom's proposal to come back to us and undertake that piece of work now to look at what impact has COVID had? Has it exacerbated our inequalities, or have we almost created another group of individuals that are now disadvantaged as a result of what's happened with COVID before they've gone to school? And then my last reflection is in relation to working on COVID as a Director of Public Health. As you can imagine, in educational settings, my focus has been on schools and keeping schools going, and the universities and the sixth forms, and how we ensure that people are as safe as possible. I've had minimal time working with early years settings to support safety because the COVID risk is much greater as children age, and the likelihood of spread of infection and the consequences of it are greater. So that worries me that my lens has been shifted away from early years setting. And what will that mean in terms of the future and this development challenge that they may have been facing during this time as they move into the school setting? So those are my key reflections, really, given what I've heard and my concerns going forward. So as I say, I welcome Tom's proposal in relation to reworking that matrix and looking at the impact of COVID. We've got more work to do in the city, particularly for me and the Director of Children's Services, in being more explicit in our strategic opportunities to work together as partners to ensure that language development is key in those early years, and we focus on it. And then lastly, in relation to tracking change, I don't think we're doing that well enough. So I'd welcome from the panel and potentially the audience as well, thoughts in relation to tracking the difference we're making for our population overall in terms of ensuring that we're reducing that inequality gap. Thank you.
Well, thank you very much, Debbie. Some really interesting thoughts there. I want to, we've got questions coming in, and I'm going to get to those in just a minute, but I just want to pick up on, following on from what you were saying there about the potential for COVID to either widen the gap between disadvantaged children and their peers, or perhaps introducing some other kind of disadvantage or difficulty. And this is a question to any and all four of you, whoever wants to respond. If that is the case, so if there's either a widening of the disadvantage gap or something else going on with COVID that's affecting some groups adversely, how should speech and language, and how should the people that put together policy responses and practical responses, how should we respond to a potential widening of the gap or a change in the gap?
First of all, I think it would be good to measure that, because I think there will be variable outcomes. When I talk to schools, some of them say that actually they've had children in, and because class sizes have been smaller during lockdown, there's been more opportunity to work individually with some kids. And of course, some children will be at home with parents more than they would have been before, and getting rich language input there as well. So I think, although I think it's a huge risk, I don't think we can be sure that everybody's going to be disadvantaged. There might be pockets where kids have actually done quite well out of it. And we've seen huge amounts of research on the impact of COVID on mental health. I think it would be great to have some research teams reporting on what the actual impact is to language and learning. That would be really, really useful. But my general view about kids is they're pretty resilient. So, and I know that schools have been working double time since they've been back in session to really help kids catch up, and I really hope that will work. I mean, all you can do is create those environments where they're getting good language input and opportunities to practice language with skilled adults as much as possible, I think.
Does anyone else want to respond on that?
I mean, I'd certainly endorse what Courtney says. I mean, the first thing is just understanding what that impact is. I think you'd have to suspect it's going to lead to a widening of the gap, but we don't know that for sure yet. And this probably cuts across a number of things I'm going to say today, and isn't specific to COVID. What we have to accept is that if the delayed language development, or the population of children who have delayed language development, are going to be very heterogeneous. There's going to be a wide range of needs within that group. But for those with quite complex needs and living in difficult circumstances, low intensity or short-term interventions are unlikely in themselves to be enough. What we need is integrated support across the life course. That's going to be about maternity, early year services, and into primary school as well. And we need to recognise that that's not going to come for free, I suppose, that if we're serious about this, we need to invest in high quality services that support that over a number of years.
I cannot agree with that more. And I do think early identification is important, but there's really little point in doing that unless you've got services that can pick up that need. And it does require investment, that is for sure. And it does need to be over the longer term and joined up thinking. We rightly have a focus on early intervention, but kids will lose ground if what they go to isn't consistent and isn't continuing to provide that kind of support. So joined up thinking is really important.
In continuing intervention. Just on that point, the top voted question so far maybe fits in a little bit with that. So this is the ELIM ready to be used now by professionals? And how does this fit alongside other early years tools like ECAT and other screening and monitoring tools for early language?
So, sorry, and I'm disappearing in the sunny North London sunlight, so sunlight in my eyes. So we wanted to get the measure out there so people could have a look at it. I think people have known it was coming for some time, so we were keen to get it out there so people could look at. What we are doing we'll roll out training on how to use the ELIM and intervention, and that will be from mid-January onwards. As I said, we wanted to do that. So our sessional trainers are health visitors, because we're using the ELIM initially at the health visiting 2 to 2.5 year review as part of the Healthy Child programme, but also really keen to stress that integration with early years practitioners, so if 2-year-olds are in settings, and also with speech and language therapy teams as well. So we wanted to get that sort of coordinated approach. We can't, this is an offer. This is an offer to families and an offer to local areas. We can't mandate this. As I've said, we know there's some really, really excellent work out there already, and people are using existing pathways, other tools. We're certainly not saying stop using those and use ours. If things are working well, then carry on. I think what we are offering is a measure that can be used for those who haven't got anything in place at the moment, and to be seen alongside our pathway documents as well. So certainly not saying stop doing what you're doing if it's working well. It's another offer of another measure.
Can I add to that? That one of the challenges with early identification, particularly in the preschool years, is that many instruments have high rates of false positives. So they pick up kids who might not have persistent language difficulties. And I think it's difficult if services are only focused on the outcome of a test. And that's why I think if you have speech and language therapy working alongside early years services, that's another way that doesn't necessarily involve a test that will help you pick up those kids who are slow to learn, and where parents and professionals might have concerns that they don't feel comfortable voicing in other ways. So I think they have a place, but I would say they also have some issues, and that more consistent working together with families and educators might be a really useful way to pick up the kids who are going to have lasting needs.
Yeah, I agree with you. And I think a really important part of the work is that we didn't want to see it just as a measure on its own, because the really important bits, and we've been trying to think of, what we call it at the moment, it's the clunky ELIM and intervention, because it was the what next. So in terms of those false positives, it was that conversation with parents, picking up any sort of parent concerns. So that's a really important element of this, not just sort of the assessment bit on its own.
While we're just on identification, there's another question on related to this. How do you see the work of the new SLC identification tool being used to help working between health visitors and early years practitioners, especially for disadvantaged children? I'll throw that one open.
mean, that speaks to my heart from, when I was a local commissioner and, commissioning health visiting services and doing early work on the integrated review. Those are really important sort of messages. I think what we want to do and make it's that integration between early years services, so early years practitioners in settings with their health visiting teams, knowing who to contact if they're worried about a child, who they need to contact. Similarly, if the health visitors know that that child is in a setting, is making contact with that setting to do some sort of focused work, joint work with that child. I mean, it's not easy. I've been doing this for a really, really long time, and some areas are doing it really, really well. And I think Tom mentioned some of the case studies that the EIF have published, and we publish sort of case studies as part of our pathway documentation as well. So there is some really good practice out there that we can learn from. But I've always said, getting these documents out there is just the first bit, even though I did have a little whoop of excitement. The magic starts when, people start using it, when people start having those conversations. We're really keen to roll this out on sort of a regional or as locally sort of based as possible, so people can start having those conversations with each other. That's when I see that things can really start to make a difference.
Can I ask you, Debbie, just from a public health, with a particular area in mind, a particular patch, and all the other things that you're having to grapple with that you mentioned, especially at the moment, is that something that as a public health service or a public health area you're able to influence or think about that work between different professionals? Courtney's highlighted it, she has as well, about how important it is for systems to work together. Is that something that comes under the purview of public health practitioners like yourself, or?
So for us in Southampton, it's a joint piece of work that we do between myself as Director of Public Health and Director of Children's Services. We've got an integrated 0 to 19 service. So we've pooled our budgets, we've pooled our services, and where possible, we've got hubs across the city where you can co-locate that workforce, so that you've got health visitors sitting alongside social care workers, linking up with others. Where it's a little bit weaker is linking with midwifery services. So going back to what Tom was saying about taking a life course approach, and back to what I think Courtney was saying about recognising the educational attainment of the individuals who then give birth, etc. So getting the whole circle working. I don't think we've quite got there yet. We've got more work to do. And I think then, although I talked, and the culture is really strong in Southampton in terms of using the ECAT. So if we move to a different approach like ELIM, I'd have to tentatively look at how that supported that culture going forwards. But I think there's more work, again, we could do to make sure we're using consistent tools and tracking, as I was saying, outcomes the same way. Because then we're all seeing the same picture. I'm always struck by the fact that we're looking at it from different lenses and focusing at different points. So we talked about specialist speech and language services, and then we talked about the population, and then we talked about development of a child or watching a cohort of children growing up. I think we need to be consistent in the approach that we're using to track that developmental change together across sectors, and that will help with that story and understanding what's happening within our city.
Thank you. Courtney, I wasn't sure if you wanted to come in there.
Yeah, well, I do. I mean, this is something that I haven't done any research on, but I would love to, Debbie. I mean, we have pretty good idea of who are the families who are at risk. And I do remember even myself having a tiny baby and thinking, oh my God, what am I going to do with this baby all day? And then remembering I could just provide a narrative of what's going on. Now, I think about that because I'm in a privileged position and I've had lots of training and I know something about child language. But I've often thought, when we do neonatal classes, which are all focused on giving birth and then changing nappies, couldn't we also incorporate stuff about how you talk to babies and how you can manage that time together and do more coaching with young mums who might really find that an overwhelming experience? And I would just love to know whether an input at that particular point in time has a lot of very cascading positive influences. One would expect and hope that it would, based on developmental theories. But I bet it would have positive impacts for mums as well and dads. But that's when you say midwifery, I think that is an area that is really ripe for further investigation.
Welcome that, Courtney. That would be fantastic. One of the things that struck me that the practitioners were talking about, although the challenges we've had this year with COVID and a lot of the work they've done hasn't been face-to-face, it's had to be virtual. They've talked about the opportunity there to discuss with young mums who have baby in bed. Why not just sit in bed for an hour, put your phone away and just talk to baby or sing to baby? And they've had that dedicated time to do that, whereas before it just would have been in, I don't know, developmental reviews for the health visitors, etc. They can have more of that conversation. That's not going to work for all groups and challenge me back. That could increase the inequalities gap. But there is also something, I think, from this year in terms of creative ways that we've enabled people to stop, pause, think, and look at new ways in which they can interact with their child. They may not have thought about it. It's not part of their culture, the way they've lived. And now we can potentially introduce something different through a different means.
I've heard lots of services say that this year has just freed them up to do things differently, and some things work and some things maybe haven't worked so much. But from a research perspective, it will be interesting to hear what those innovations have been, and then to find ways to test them more robustly. But I think everything's up for grabs now. So that's one of the positive things, I think.
Thank you both. I'm going to pick the next question off the list. We've got tiebreakers, but the next one. Has anyone looked at evidence to understand language acquisition delay in relation to the ability to communicate effectively to support relationships? Is there a link between language delay and family functioning? We know language skills are so important for constructive conflict. So interesting link there. Would anyone like to pick up and reflect on that?
I'm not sure exactly what they're asking for. I mean, certainly in our research and other studies have shown that language is absolutely critical for social relationships. And so kids who have language disorders are far more likely to have peer problems. They have our own data is showing that early language skills are predictive of later abilities to recognize emotional cues from faces and voices. Language is also really important for emotion regulation. So if you're feeling stressed, we use a lot of self-talk to get ourselves through tricky situations. So I think there's quite a lot of evidence that language presents challenges for developing social understanding and for developing and maintaining social relationships within families, but also outside of families as well.
Thank you. One of the other things that question made me think of, and maybe in relation to some of the EIF reports, that actually sometimes we're thinking about disadvantage in relation to language gaps, disadvantage in relation to family conflict, and sometimes we're talking the same things obviously cluster up. I wonder, because obviously you've written lots of these reports and in lots of these reports, Tom, whether you have any thoughts on that, like whether to what extent these are the same disadvantages that are playing through different aspects of family functioning, or where they might be different.
I think that's absolutely right. I mean, we talk a lot about the interrelatedness of developmental competencies, the idea that cognitive, social, emotional, behavioural and physical development are all strongly interrelated. You can find that gross motor function is predictive of language development and educational performance and so on. So I think it's really important that we understand that speech and language is a very important indicator of school readiness, of how children will perform at school. But it's not the only thing that matters in the early years by any stretch of the imagination. That it's perfectly possible that children can have very high, good functioning language, early language and communication skills, and yet have behavioural difficulties and so on. And what we consistently find when we look at this is poverty is nearly always the best predictor of delayed development or atypical development in any one of these domains, and they're all interrelated. So if you're experiencing speech and language development problems, you're more likely to have behavioural problems or social and emotional problems as well as that. So I think the role of nothing comes out more strongly in anything I've ever looked at than the poverty or social or economic disadvantage as a predictor of delayed development. That's just a consistent message of everything we look at.
Thank you. Another question here that picks up a little bit on what we were, Sheena, you were talking earlier on about the kind of the links and the system links. And thinking about the transition, Courtney, you made a very strong point about how intervention needs to be ongoing. If it's going to work, one hit early on followed by nothing isn't going to be very terribly helpful. So the question picks up a little bit on that, I think. How can we improve the transition from health visitors to earlier settings to ensure that information gathered about a child's speech and language development are picked up on and continued? What's needed is a systems level approach to support long-term development for children, which I think everyone will probably agree with, but what can we practically perhaps do to ensure those transitions and that information is continued so that intervention can perhaps also continue? Does anyone want to pick that one up?
I mean, I think that sort of goes back to sort of good information sharing, good relationships, communication between services. I feel like it's something that we've been talking about for a really, really long time. Debbie might have something to bring into this one as well. But I think, you know, from my work back in the day when I worked locally, it was sometimes it was really quite simple. It was knowing who your local health visiting team was, who your local, you know, where your local early years sort of settings were. I think the integrated review that we sort of started to do, you know, a long time ago, and I know some areas are still doing, sort of went some way towards that in terms of sharing information. Because we're talking about the same children and families. I think there are different reviews, you know, the progress check at 2 in settings, the health visiting 2 to 2.5 year review, you know, but ultimately it's the children and family at the heart of that. And so telling the story to different people looking at slightly different things, I think the important bit is how that works and how that joins together. And I know there are some areas that are doing that really, really well, that we can learn from.
Thank you.
Right, Sheena, I think it is very much about relationships at the end of the day. I've come to learn that from more than anything from local authority working, and particularly this year with COVID-19. Build those relationships, build trust, work together, and then you can make magic happen, essentially. I think there's also something about system leadership and consistency in approaches. So we talked about tools, etc. So I, Director of Children's Services and other, can support certain ways of working, frameworks, tools, resources, making sure we're consistent across those sectors and what we're using. So we're speaking the same language essentially as well in understanding that journey that a child and a family are going through. I think that's also key. I think they were probably the key points. There was something else, but I've forgotten. Sorry.
We'll have a chance to come back around. I've got a question, building on what Courtney was saying about the prevalence of some of these difficulties, and you gave us rates of 7 and 10%, Courtney. So these difficulties are really common, and I suppose I'm curious as to, this is to all 4 of you, whether you think there are any systemic reasons or any particular reasons why speech and language inequalities get overlooked when they're so common. And if there are some systemic reasons or particular reasons, is there anything that we can really make sure we do about that going forward to make sure that those disadvantaged gaps and that overlooking doesn't continue to happen?
Well, I think one issue is language is so important for advocacy and self-advocacy, right? And we haven't traditionally, speech and language therapy hasn't traditionally been very good at making diagnoses. So often kids will have difficulties, but nobody's ever sat down with parents and said, I think your child has a language disorder. And once you have that diagnosis, then, you know, if you are able, you can find out more about it and you can press for services and things like that. Now, we know very often, not always, but often language disorders run in families. Those families themselves might have challenges with language. They might have challenges with literacy. We don't have professionals sharing that information about diagnoses, so it doesn't go anywhere. If you think about other developmental conditions, you know, often parents are able to say, my child has this condition, I want you to do something about it. And that raises awareness, and that, you know, presses politicians and policymakers to do something about it. That's part of the reason why we have rattled we have a condition where the terminology has been inconsistent. Not many people have a general awareness of it. So it becomes much more difficult to press for those services. So that is something we're desperately trying to change. And I think that the work that the EIF does and Public Health England have done really does help to raise awareness of how important it is. And my sincere hope is that will trickle down to things like research funding, raised public awareness, and families being more able to advocate for themselves and for their children.
Tom, did you want to come in?
Yeah, I'll just offer a few thoughts. I mean, I think one of the reasons is potentially it's not like we've got all the answers as to what works here. We know some of the things that do work or are likely to work, but I don't think any of us are sat here with the answer to how to better support 10% of the population to overcome delayed language difficulty. So I think there's something in that. Across all areas of early intervention, it's difficult to make the case for this, isn't it? Long term, we're talking about long-term investment that you won't see a payoff for many, many years. You're asking often local authorities to invest when the benefits will accrue to different parts of the system. So this is just an ongoing challenge, political challenge about how you support children and make the case for long-term investment. But I guess I might just finish with a positive note that. There's lots of good work going on. I'm genuinely heartened by the work that DfE and Public Health England are doing. That there's lots of good initiatives in place that have come on the back of the Social Mobility Action Plan. What I really hope is for a long period now, that we don't get a new ministerial team or a new focus, a new area of development, that we actually say, well, we've chosen to prioritise speech and language, we've chosen to invest in new measurement tools, new training programmes and so on, and we're going to actually sustain and evaluate that and understand if that works. I'm going to make adjustments to that if things aren't working as we expected. But let's give credit where it's due. We are making speech and language a much bigger focus of early years development than it has been historically.
That's going to be our last question. I think Sheena or Debbie, you want to add anything very briefly on that before I wrap up?
Just a couple of things. I think poverty is seen as entrenched, so that's the big challenge in terms of a marker in relation to speech and language development. So it's really important that we show we can make a difference in terms of providing these services. That helps us invest into these services even more. So again, the support of PHE and the Early Intervention Foundation has been key in helping us with those frameworks and thinking through how we track those outcomes going forwards. But I know I need to do a lot more work on that. The other thing I forgot to say, and again to try and end on a positive note, the other thing that works really well in the city, and I don't doubt that's the case in many areas, is CPD, so continuing professional development. And again, practitioners from all workforces, whether you're in an early years setting, you're a private provider, you're a health visitor or a midwife, you come together. We have conferences, we have opportunities for people to share their learning, and I think again that helps with that relationship building. So important part of work.
Yeah, and just lastly, just really heartening, I've been talking to commissioners and to providers of services and thinking that, this wouldn't be something they would focus on because there's so many other priorities at the moment. And I've just been really, really heartened to see that people really do want to focus on this. They do really see this as something really important that they can influence and there can be sort of changes. So yeah, I've just found that really, really encouraging.
Thank you very much. Well, thank you to the audience for joining our session, and thank you very much to our speakers, Sheena Carr, Courtney Norbury, Tom McBride and Debbie Chase, for your insights and expertise on this particular topic. It's been fascinating.